Hello everybody, I'm Jan Lanki. Jim Ferdy, the head of department from the Gynae department, asked me to repeat this talk. I've given this talk about a week ago to our doctors. As you all have heard about the coronavirus and noticed how quickly that virus might change our lives, this talk might already be out of date in some aspects, but I have tried to update it as much as possible. So I prepared these slides about 10 days ago. So some things are different nowadays, especially the numbers. But today I want to give you an overview about the coronavirus and how it impacts our maternity ward, and hopefully give you some information to make you more comfortable in talking to your patients. So the coronavirus, COVID-19, SARS coronavirus 2, that's all the same basically. The coronavirus, the name is basically an overview of all coronaviruses that are around. COVID-19 is the disease, the coronavirus, SARS coronavirus 2 creates. So the actual name of the virus is this one, and COVID-19 is the disease. Why did I prepare this talk? Because I have friends in Germany and I talked a lot to them, and there's quite a lot of people that are really thinking of their own, not thinking of others, and I don't want to be one of these. And I also don't want to be a gynecologist that has to treat pneumonia. And a lot of information around, or things that have been said, have been around, that I think we need to work on. Why are we panicking? It's just a flu. It's not just a flu. I brought my flu vaccine forward so I won't get it. That's also not accurate. Coronavirus is something different than the flu. It has always been related to international travel, which has been the case until yesterday, as you all might have heard. And it's only dangerous for elderly people. That's true, it's more dangerous for elderly people, but it's not only dangerous for elderly people. And it'll disappear like it came. This sentence was said by Donald Trump, as you might have heard in the news. So it won't disappear. It will disappear over time, but we have to make sure it disappears in a different manner with too much impact on our healthcare system, because all healthcare systems around the world are in big trouble if we don't take it serious. And that's a message from a friend in Sweden. He sent me a couple of days ago. They had a 27-year-old on ICU related to coronavirus, and a third of the ICU patients in Sweden are 65 and under with no underlying disease. So it's not only affecting the elderly and comorbid patients. This is a typical number. This is the cases in Germany. So we basically had no numbers in Germany until beginning of February, and then out of a sudden it shoot up, and that's the same numbers in all around the world. So on 22nd of March we had 304,000 confirmed cases with 91,000 recovered, and almost 13,000 died of the coronavirus disease. And as you can see down here, US has already taken third place, thanks to probably part of Donald Trump, thanks to some people not taking too serious. There are other countries, so this is a slide, curves of cases in countries, and as you can see, most of the countries have a very steep line of cases going up, but there are some countries like Hong Kong, Singapore, that have low numbers. Although Singapore was one of the first countries that had the coronavirus after mainland China, and the same with Hong Kong. What did they do different? Hong Kong closed borders and schools very early and had a strong community response, and that's why I'm giving the talk, because it's our responsibility to accommodate that. And they had strict quarantine rules. Singapore, interestingly, had low numbers, but didn't close the schools, but they had very strict quarantine rules and contact tracing, and they have been testing basically everybody, not only the ones that had travel-related diseases. So I want to give you some basics about the coronavirus. Coronavirus is a non-segmented RNA virus. The COVID-19 is part of the family of coronavirus. This contains basically 4 groups, widely distributed and usually causing the common cold, but can cause pneumonia in comorbid patients. And you might all have heard of the SARS virus and the MERS virus. These are also coronavirus, but more frequently causing high mortality due to pneumonia and lung damage, especially the SARS, which has been in 2003 in Singapore, and that's why Singapore is now prepared much better than other countries. It binds via the angiotensin converting enzyme, the ACE2 receptor, which is located on type 2 alveolar cells and intestinal epithelia. So that's where we get infected. We can get infected via our lungs and via the intestines. This is the same receptor used by the SARS-1 in 2003, and that's why the name is SARS coronavirus 2 now, and the previous one in 2003 is called SARS coronavirus 1. There is not one coronavirus COVID SARS-2 virus. It's basically a virus that is mutating constantly, and we don't know yet what that means for the future. It might make the disease less aggressive or more aggressive, but there is evidence that there are basically 2 main groups of the virus around. This is how it's not to confuse, it's just to show you how many viruses are around, or different types. It has started here in Wuhan with the L haplotype, which is more frequent all over the world, and it's more common in early outbreak, and it's more responsible and more virulent, compared to the S haplotype, which is less prevalent all over, seems to be less virulent. How can we transmit the virus, or how do we get the disease? The transmission can occur via large droplet transmission. So risk limit, you can reduce your risk by keeping distance to patients or to other people. This is typically for respiratory viruses such as influenza. Transmission via large droplet transmission can be prevented by wearing a surgical mask in the hospital or at home. If you're sick, you should wear a mask if you go to the doctor. However, there is discussion about if there is also airborne transmission. Airborne transmission means that the particles that contain the virus, that contain viable virus, are smaller, so these particles remain longer in the air, and it can be transmitted in a room. If you stay longer in the same room, you could get the transmission of the virus via the airborne transmission. So airborne transmission would imply that we have to wear a more an N95 mask, so a filter is better for a virus rather than a surgical mask. So recent studies showed that the virus remains in the air for about 4 hours, but the amount of viruses drops about every 70 minutes, so it halves about every 70 minutes. So this is a 95 mask compared to a surgical mask. We would have to wear that if that is the case. At the moment it looks like the main transmission is contact and large droplet transmission. But so this is guidelines that disagree, some disagreement. Canadian World Health Organization and Australian New Zealand guidelines recommend surgical masks for routine care of patients. But if you have aerosol generating procedures like intubation, extubation, and so on, you should wear an N95 mask. That means for us, if we have to do a cesarean section category 1, we should wear N95 masks. And that's what it's gonna be when we wear the mask during the procedure and having a face shield as well, and obviously gown as well. The United States recommend airborne precautions at all times if you deal with COVID-19 patients, so N95 masks at all time. But they are now already running out of these masks, so it's probably wise to wear a surgical mask if you're not doing these procedures as mentioned here. Contact transmission. This transmission is often overlooked, but it may be a large contribution to the spread in the community. So it works like someone with a coronavirus coughs and emits large droplets containing the virus. The droplets settle on surfaces like tables, glasses, handles, and it can stay about 4 days on a metal surface or glass surface. And then a second person comes, touches the same surface, has it on the hands, and then touches his face and the mouth, and then via that route you get the infection. So any effort to limit the spread of the virus must block contact transmission. So we can do that with regular cleaning in the hospital, also at home. Hand hygiene is most important, and avoidance of touching your face, which is very tricky because we touch our face constantly without noticing it. And that's probably how surgical masks also work at home or in the hospital. If you wear a face mask, you don't touch your mouth. Any medical equipment could be contaminated, so that's why we have prepared in our maternity ward to clear the rooms where the possible COVID patients are treated. So no other equipment is in the room rather than the ones we need. But the good thing is it can be easily cleaned, the surfaces. So when can transmission occur? Asymptomatic patients can transmit the virus. It's about 2 days prior to your signs. If you get sick 2 days prior to that, you can transmit the virus. And that's the problem. That's why we have probably in the community already cases we don't know yet. Transmission appears to occur over roughly 8 days following the initiation of illness. That means once you get the symptoms, you're probably infectious about 8 days. But depending on the severity of your disease, it might be longer. Guidelines are quite not that precise about when to isolate all over the world, but our guidelines, Ministry of Health, is this one: if the patient has been isolated or sick, we can release the patient from isolation on a confirmed or probable case if the resolution of symptoms have occurred 24 hours before, if there is no temperature for 48 hours, and the disease acute onset is at least 7 days ago, and the patient shouldn't have major immune suppression or being on having had a bone marrow transplantation or on chemotherapy. If this is the case, the patient should be isolated longer. So these are our responsibility and our weapon against the virus. So the 5 M's: manage your health means check your temperature regularly. If you have signs for an infection, stay at home. Maintain clean hands, minimize contact, mask up if you are unwell or if you go to the doctor. That is probably most important before. So if you get sick or your patient gets sick, you should call Healthline and then wear a mask when you come to the doctor so that you don't spread the virus. And monitor the news, which is also very important because the virus is changing our environment and recommendations basically every day. So please monitor news and guidelines and recommendations of any authority bodies or colleges. These are habits everybody should do. Wash your hands, monitor temperature, as I said, sneeze and cough in a tissue or in your elbow, litter. If you have used tissue, throw it away that nobody else will touch it. If you're in a restaurant, which probably is not the case anymore, remove your stuff your own and keep surroundings clean at home and the toilets clean, which is normal, I would say. Contact distance, social distancing, as everybody is saying now. I think everybody heard of that. No handshakes. Keep at least 1 meter distant. Probably 2 meters is better. And use video conference as much as possible, also in the contact with patients. Now, important topic, the PPE, personal protective equipment, which is we should have contact precautions. That means we should wear a waterproof gown, we should wear gloves, we should wear a mask, as I said, N95 mask for aerosol producing procedures, otherwise surgical mask is enough. Goggles or eye shield and face shield, hair cover for aerosol generating procedures. I would say it's probably better to wear hair cover all the time if you deal with a patient. And shoes, you don't have to cover your shoes. You probably should wear shoes you can easily clean. Probably the exact gear is not as important as using it correctly. Putting the gown on and the protective gear on is something we know and we do daily in theater, so we are quite familiar and confident with that, but doffing the PPE is the important part and tricky part. So this is how it works. Inside the patient room, you should clean your gloves with ethanol hand sanitizer before you remove anything. Remove the gown and gloves and try not to touch anything which is outside, like gloves outside, gown outside with your hands. After you have removed the gown and the gloves, clean your hands. Remove the face shield, clean your hands again, and then you step out the room and remove your surgical N95 mask. That's to be cautious of the virus that might be floating around in the air. That's why you remove your mask outside and then you clean your hands again. Some pearls about the PPE. Pay attention to the junction between gloves and gown. The gown should be tucked into the gloves. Using gloves with extended cuffs might make this easier. Gloves with long cuffs also facilitate removal of the gown and gloves as a single unit. When removing PPE, always start by first applying alcohol sanitizer on your gloves. After fully removing, sanitize hands and wrists with alcohol and consider doffing with somebody who is watching you to tell you, oh, inadvertently touched this, you need to clean your hands again. And here is a link about doffing on YouTube, which is quite helpful, I think. How does the virus make us sick? So the first response might be IRDS, acute respiratory distress syndrome. So this is characterized by diffuse alveolar damage. Pneumocytes with virus cytopathic effect are seen, implying direct virus damage to the tissue. The second response is the cytokine storm. So our immune system then responds to the virus, and there is evidence that some patients may respond with an exuberant cytokine storm reaction, which features of bacterial sepsis, but it's not bacterial sepsis, or hemophagocytic lymphohistiocytosis. That's a difficult word. But this one is basically an overreaction of your immune system by lymphocytes and macrophages that are releasing cytokines like crazy, and this is a life-threatening condition. And clinical markers of this may include elevation of C-reactive protein and ferritin, which are acute phase infection proteins, and which appear to track with disease severity and mortality. I'll come to that later. So there are different stages of illness. This seems to be stage 1 with the replicative stage where the virus gets replicated. An innate immune response occurs, but this fails to contain the virus. This is associated with relatively mild symptoms, may occur due to direct viral cytopathic effect and innate immune response. Then we have the adaptive immune stage. This is the more dangerous response. An adaptive immune response eventually kicks into. This leads to falling titers of the virus. However, it may also increase the levels of inflammatory cytokines and lead to tissue damage causing clinical deterioration. There is suggestion that this could lead to virus-induced hemophagocytic lymphohistiocytosis as mentioned before. This progression may explain the clinical phenomenon that patients are relatively okay for several days and then deteriorate. And this has potentially important clinical implications. So initial clinical symptoms aren't necessarily predictive of the outcome of the future. So sophisticated strategies may be required to guide risk stratification and disposition. Antiviral therapies might need to be given early in the onset of disease. This is an overview of the stages. So initially we have the viral response phase, then we have the host inflammatory responsive phase. That's the phase where people get really sick. So symptoms when a patient presents to the hospital, as you all have heard: fever, myalgia, headache, mild symptoms, upper respiratory, rhinorrhea, sore throat, lower dyspnea, chest tightness, cough. Hemoptysis is very rare, but also not to forget is gastrointestinal symptoms. Typical disease course: incubation is a median of 4 days, with a range up to 14 days. That's why we have the 14 days quarantine if you might have had contact or travel. Typical evolution of severe disease is about 6 days post-exposure. Admission to the ward is about 8 days of exposure, and admission to ICU after 10 days of exposure. However, this timing may be variable. Some patients are stable for several days after admission but subsequently deteriorate, or you have severe onset earlier on. How do we test for the virus? We should do the real-time PCR for the virus, so this detects virus RNA straight away. We should take swabs of the nasopharyngeal, should be sent but deep in the nasopharynx to get enough tissue. If intubated, tracheal aspirate should be performed. There are limitations to the testing. If you're not taking it appropriately, the test might be negative. Also, COVID is not a binary disease. That doesn't mean if your test is negative you don't have it. There's a spectrum of illness. So sicker patients might have higher viral burden. It's easier to detect early. If you have early disease, minimal symptoms, your test might be negative, but you still have it. Most current studies lack of gold standards about how to diagnose. As I said, there is a study of positive CT scan and negative PCR, and there is patients that have false negative PCRs at the beginning, and then later on they have positive tests. Specificity and sensitivity of the test. Specificity, that means if the test is positive, the patient really has it, is quite high. But sensitivity, that means if the patient tested negative, it doesn't mean he's negative. So the sensitivity is not quite terrific. It's about probably 70 to 80%. There have been several studies showing that. I won't go in further detail with that. Imaging, when a patient comes in with coronavirus disease, all imaging is not specific. Imaging cannot differentiate between the coronavirus infection or other forms of pneumonia, and imaging could help to differentiate between a coronavirus infection and non-pulmonary disorders. These are typical ultrasound images of an infection. So basically here are ribs, and in between is the pleura, and from the pleura you have these infection spot, and you have these lines down. These are called the B lines. If the B lines are confluent, looks like that. And the CT scan has a typical ground glass peripheral damage to the lungs, and most often at the basal part of the lungs. Lab tests, complete blood count, white blood cell counts tend to be normal, but lymphocytes are less, and that's very often in 80% of the patient. Mild thrombocytopenia is common, and lower platelet count seems to be a poor prognostic predictor. Other lab tests, coagulation studies, coagulation labs are generally fairly normal, but elevated D-dimer might be a poor prognostic factor for the future. So here are the usual PTT and APTT. So green are non-survivors and black are survivors. You see the difference in these numbers, and these are the D-dimers. Green again non-survivors, black survivors. If you have higher D-dimers at admission, and later on the likelihood for poor prognosis is higher. Inflammatory markers, as I said, C-reactive protein might be higher. Procalcitonin is an infection marker for for bacterial infection, not virus. So these are usually normal. That is helpful to differentiate between viral and bacterial infection. If procalcitonin would go up later on, that means there is a superinfection with a bacterial pneumonia. C-reactive protein, as I said, it looks like that the lower the rate at the beginning is, the less likely is a bad outcome. Evaluating other diagnoses, PCR for influenza and other respiratory viruses might be necessary to differentiate between both. Now we are having the start of the influenza season 2, so it's helpful to get vaccinated with influenza. If you're a healthcare worker, you can get the vaccinations already now. If you're not, you will get the vaccinations in April. So I would highly recommend getting the vaccinations. Conventional viral panels for coronavirus is the usual for coronaviruses, but it doesn't work for the COVID-19, so we have to have special tests for that. Ironically, if you have a positive normal coronavirus test, it's less likely that you get the COVID-19. General prognosis, it remains unclear what fractions of patients are hospitalized, because we're not diagnosing everybody who has it, so mild cases might not be representative in these numbers. But the vast majority of infected patients, over 80%, don't get significantly ill, and that's what we have to keep in mind. Most of us won't get seriously sick, but we are responsible for the others who are in more danger that they don't get sick. Among hospitalized patients, about 10 to 20% are then admitted to the ICU, and that is the big problem for the health care systems. If we have too many cases, we don't have enough ICU beds, and that's what's happening in Italy. 3 to 10% require intubation, and 2 to 5% of admitted patients might die. What are risk factors? Epidemiological risk factors is older age, coronary heart disease, hypertension, diabetes, chronic pulmonary disease. These are numbers from Italy. I got these numbers and a slide from a colleague in Germany who attended a webinar from an Italian doctor. As you can see, all the numbers, all the comorbidities, as I mentioned before, are associated with higher risks of disease. So these are 268 patients that died in Italy from 2016. This was beginning of March. If you have no comorbidities, the risk of dying is very low. The more comorbidities you have, the higher the risk of dying of the virus. Speaking of Italy, they had 800 deaths within 24 hours 2 days ago, because their healthcare system is overwhelmed. And risk factor age, these are also numbers from Italy, so the older you get, the higher your risk is of dying of the disease. So are there any risk stratifications we can predict the outcome? Lymphopenia seems to be a predictor. Neutrophil lymphocyte ratio seems to be a very good predictor. If you have more than 3, that seems to be a predictor for poor prognosis. As I said, the higher the CRP or ferritin lactate dehydrogenases or didimer is, also this seems to be a strong independent predictor for mortality. Troponin is a prognostic factor if you have underlying heart disease, but it might be tricky to see what levels are really the challenging or the levels that are causing issues. And here again, the numbers of lab results. Here, red ones are the non-survivors and blue ones are the survivors. So here is didimer. The higher you can see the numbers are, the less likely is to survive. Here is lymphocyte count. So low lymphocyte count is a poor prognostic factor. Ferritin, high levels, poor prognostic factor, and also with LDH. How should we avoid unnecessary emergency department visits and clinic visits? That's a major thing. As I said, 80% of people don't get severely sick, so these shouldn't attend clinics or the emergency department. So we have put in place the health line. You should call if you have symptoms, and they will guide you to our community-based assessment centers where you get tested and then get sent home again. In many other countries there are drive-through testing, so you stay in your car and get tested and then you drive home again. When can somebody stay at home? As I said, most of the patients can stay at home. Patients with mild symptoms can be discharged home with instructions to isolate themselves. These decisions should be made in coordination with our local health departments and can assist with follow-up. Healthline is a good source for that. Features favoring home discharge is ability to understand and comply self-isolation. That's the most important thing. Probably helpful is a separate bedroom and a bathroom so that you don't infect others of your family. Ability to call assistance if you get more severe sick. Having household members who aren't at increased risk. So if you're living with an elderly comorbid patient, then you probably should not self-isolate with your granddad, or if you have a pregnant woman at home. Lack of hypoxemia, so if you're having issues to get enough breathing, then you should not be self-isolated at home. Now, our topic about pregnancy and COVID infections. We don't have much data about COVID infections in pregnancy, but I'll try to give you as much information as it is available at the moment. Clinical characteristics of patients with a COVID-19 infection present from mid-trimester onwards are similar to non-pregnant. At the moment, there is no evidence that pregnant women are more susceptible for COVID infections at the moment, although there might be concern because pregnancy is sort of a state where your immune response is lower because you have part of your baby is foreign body to you, so your immune system is a bit suppressed. Severe morbidity and mortality are not evident in pregnant women yet, but there are not many cases reported. There are about 12 case reports about pregnant women in China. So we don't have enough data to really say yes or no yet. There is lack of information about vertical transmission, but the case report, it's a report from China, say that there is no vertical transmission, but we need to collect more data. So if we have a COVID positive patient and they deliver, then we should keep placenta, send placenta, take bloods of the baby to make sure that we support these data that are available. How should we triage patients that are scheduled for our outpatient clinics? Most of our outpatient clinics can probably be done via telephone conference, but for somebody who has symptoms or has been traveled or had contact to somebody, they should probably postpone their antenatal clinic visit and also your clinic visit with you as a midwife. And this is a plan of our maternity ward. So here is the usual entrance. Here is our antenatal rooms where we usually examine patients. Here are our delivery suites. And we have now divided the maternity room into red zone and green zone. Red zone means this is the area if we have a confirmed case in our maternity ward, we will lock down this area and separate it from the green area. So here will be the patients that are confirmed or suspected cases, and the green area will be the area of non-COVID patients. So this is the entrance to the rehab, so this will be the main entrance for all patients coming in. If a patient is in labor, they should deliver either in B1 or in room 14. Postnatally, they should stay in C1 or C5, and we assess possible infected patients or infected patients in the C2 to C4. For our antenatal visits, not antenatal clinic, but if you present with a woman to be checked because of high blood pressure or something, they will be assessed in room 1 and 2 if they have no signs for coronavirus infection, no risk factors for that. Antenatal care, it's important to screen all our patients, so we should ask everybody now about symptoms so that we can detect early if somebody is sick. If patient has risk factors for travel or contact or symptoms, they should stay at home and we should postpone the visit for 14 days. Antenatal examination of pregnant women infected with COVID should be carried out in a negative pressure isolation room. That would be ideal, but we don't have that, so we should treat them in our red area, and human traffic around this area should be limited. Apologies for the quality of these slides, but these are slides from a colleague in Germany that sent me these through, which is basically data from Italian experience. COVID-19 itself is not an indication for delivery unless there is need to improve maternal oxygenation. Timing and mode of delivery should be individualized, dependent mainly on the clinical stages of the patient, gestational age and fetal condition. In the event that an infected woman has spontaneous onset of labor and progressing well, then she should be allowed to deliver vaginally. Shortening the second stage by operative vaginal delivery can be considered, as active pushing might spread the virus in the air, and these women should ideally wear the surgical masks, but this might be tricky if you're actively pushing and having the mask, so it might be a consideration to assist with the vaginal delivery. With respect to pregnant women without a diagnosis of COVID-19 infection but who might be carrier, we should use caution regarding the practice during active pushing while wearing a surgical mask. So probably if you think somebody might have it, we should treat them also in the red zone area. During labor, induction of labor can be considered if the cervix is favorable, but there should be a low threshold to expedite the delivery when there is fetal distress, poor prognosis, and poor progress in labor or deterioration of maternal condition. That's basically what we do normally. Septic shock, acute organ failure, or fetal distress obviously prompts emergency cesarean delivery. If it's early in pregnancy, we might have to think about terminating the pregnancy if the patient is not getting better. For the protection of the medical team, water birth should be avoided. Regional anesthesia and general anesthesia can be used as usual. If general anesthesia, we should use PPE and the N95 masks. If a positive tested patient needs epidural, obviously we wear our PPE anyway. For preterm cases requiring delivery, we urge caution regarding the use of antenatal steroids because fetal lung maturation is critically ill patients. So if somebody is critically ill, we should probably avoid antenatal steroids and deliver baby to assist the recovery of mom. But this should be discussed with infectious disease specialists and MFM and neonatologists. It also depends on the week of gestation. So probably we shouldn't give steroids at 37 weeks, which we would usually do if we plan a cesarean section for that in a critical ill patient. In the case of an infected woman presenting in spontaneous labor, tocolysis should not be used in an attempt to postpone delivery to administer steroids. As I said previously, we should keep miscarriages, fetuses, placenta to check if there is disease transmitted via vertical transmission, so that we have more data available in the future. How is the neonate managed at present? There is limited data that there is no evidence of vertical mother-to-baby transmission, as I said. For suspected and probably confirmed cases following delivery of the baby, the umbilical cord should be clamped promptly, and the neonate should be transferred to resuscitation area for assessment by the attending pediatric team. I don't think that we have to have a peds team present for every birth on an infected patient. However, if there are concerns with CTG prior to that, our threshold calling a neonate team should be lower, but not in general. There is currently insufficient evidence regarding the safety of breastfeeding and the need for mother-baby separation. If the mother is severely or critically ill, separation appears to be the best option, with attempts to express breast milk in order to maintain milk production. If a patient who has COVID-confirmed disease delivers and baby needs to go to the neonatal unit, the neonatal unit is green area and should remain green, so women and dads unfortunately are not allowed to see their baby until they have recovered. The neonatal managed part 2. If the patient is asymptomatic or mildly affected, breastfeeding and collocation can be considered as long as mom and dad understand the disease and how disease is transmitted. Since the main concern that the virus may be transmitted by respiratory droplets rather than breast milk, breastfeeding mothers should be ensured to wash their breasts before they breastfeed and wear a surgical mask before touching the baby. In case the baby is in the same room, there should be a distance of 2 meters and probably a physical barrier like a curtain should be placed. Babies of suspected or confirmed cases that require NICU admission are isolated and parents won't be allowed to visit the NICU, as I said. Pregnant ultrasound. This might be a problem in the future when private companies or private providers might not be able to give us the same amount of ultrasounds we usually have because they have a confirmed case or they get sick. This could be a problem in the future. So pregnant patients with a known risk factor should postpone their routine ultrasound by 14 days. For suspected or probably confirmed cases, when ultrasound is appropriate, carry out ultrasound for fetal growth and AFI with umbilical Doppler. A bedside scan is preferred. So that means probably in our hospital we might do more bedside scans in the future. Woman with suspected COVID infection or confirmed infection and are asymptomatic and recovering from mild illness should be monitored for fetal growth and AFI with umbilical artery Dopplers every 2 to 4 weeks. This might also increase the need for ultrasound in the future. The pregnancy should be managed according to clinical and ultrasound findings as usual, and the infection is acquired during the first or early second trimester of pregnancy. A detailed morphology scan, as usual at around 20 weeks, is indicated. But if the patient is sick, you should postpone it for 2 weeks. Once we use the ultrasound, we have to clean it and disinfect it. As always, consider using protective covers for probes, which is probably something we do in the red zone area, and we might need to deep clean it afterwards. Where should we treat patients or place of care? Pregnant women with suspected or confirmed cases should be managed in the hospital. These cases should be treated in isolation rooms, which is our red zone area. A woman with confirmed infection is critically ill should be admitted to a negative pressure isolation room in the ICU ideally, but I'm not quite sure if our ICU has that. All attending medical staff should wear PPE. So once you enter the red zone area, you always have to wear PPE. However, in the future there might be, hopefully not, but there might be so many cases that we are not able to isolate women in a single room, and if women are confirmed COVID cases, they might be placed in the same room. So key points: management of COVID infection in pregnant women should be undertaken by a multidisciplinary team, so we need to start talking to each other early in the disease: obstetricians, MFM, intensivists, anesthetists, and microbiologists. Medical staff who are caring for suspected or confirmed cases need to be monitored closely for fever, so we ourselves should test our fevers regularly, twice a day, and if we are having symptoms we should stay at home, and we always have to wear PPE. If medical staff was unexpectedly exposed, we should self-isolate for 14 days. Pregnant healthcare workers should follow risk assessment and infection control guidelines. At the moment, for pregnant women, the Ministry of Health guideline is that these women should stay at home. You all have heard the news yesterday, I suppose, and these are the levels, alert levels. At the moment we are at level 3. We have been level 2 when I prepared this slide, so at-risk people should self-isolate, and it was mentioned that pregnant women should self-isolate as well at that stage, but now we're already at level 3. That has implications for all of us. Travel in areas, and soon we are level 4. From Wednesday midnight we are level 4, so travel should not be undertaken if not necessary. Mass gatherings should be avoided. Schools will be closed or are already closed, and we should find ways to work from home. And this is something for the LMCs, which is important. Non-face-to-face primary care consultations should be undertaken as much as possible. There are cases where you need to see the patients, but then you need to ensure that these patients don't have symptoms or are sick or have risk factors. Non-acute services and procedures in hospitals are deferred, and healthcare SAR is reprioritized. That has happened in our department and hospital already. Level 4 has major reprioritizations of the healthcare system, and all businesses are closed except supermarkets, pharmacies, and clinics. And as probably you already heard too, supermarkets will stock up as we give them a chance, so please shop as usual. Pitfalls for the coronavirus infection: delayed consideration of a COVID infection if the patient only presents with gastrointestinal symptoms, treatment of COVID based surviving sepsis guidelines. So a COVID-19 patient usually does not present with sepsis, but later on during the disease it might present like sepsis, but we shouldn't treat it like sepsis because we shouldn't overload them with fluid. Inadequate attention to contact precautions, so hand hygiene, sterilization of surfaces, not wearing PPE. This is something, or not wearing the right PPE, or when you doff the PPE you make mistakes. Admission of patients to hospitals who could be safely managed at home, and use of the emergency department as a screening area. As I said before, emergency department is not the screening area. So final tips: please take it serious, screen your patients, do not admit a patient or see patient without having asked them the important questions, take temperature, wear PPE in suspected cases and confirmed cases, and give good advice to your patients. Thank you. And this is the literature where I got it from my information, Ministry of Health. This is a very good website to have a good overview also about treatment. The website of the Singapore Ministry of Health was very helpful, and lots of experience from European friends. Thank you, everybody.